Welcome everyone to the first OC3PR for 2022. I am sure you share our hope that this will be a better year than the last one. Unfortunately, with the surge of COVID cases, it sure seems like we're experiencing 2021 all over again, rather than starting a brand new one. That said, I am actually still reasonably hopeful that the latest surge will be the final one, but certainly time will tell. And although it seems that our experience is to always discuss and address COVID issues, it's important to remember that other problems continue to exist and can no longer be ignored. It is therefore fitting that today, with our expanded focus for OC3PR, that we will be discussing a medical issue that has always existed, and though has greatly been reduced in occurrence, it will likely never go away. And so it is important that all health professionals be knowledgeable and be able to address it. Ontario's Critical Care Clinical Practice Rounds, or OC3PR, is the monthly educational series sponsored by Critical Care Services Ontario. Its mandate is to help provide the skills and knowledge to health professionals, be they medical providers or administrators, all of us who help ensure that the care provided to the critically ill patients is that of the highest possible standard. All of the previous OC3PRs are available either from the CCSO website or from their YouTube channel, which we encourage you to check out. For today's session, you will have the opportunity again to submit questions via the Zoom chat feature. We ask that you send them to the people named Q&A for question and answer. Today's questions are being fielded by Drs. Neill Adhikari and Dr. Bernard Lawless, who represent the OC3PR committee. As always, we ask yourself to keep yourself muted for the presentation. As mentioned before, today's topic is an important one to review as it is an issue that continues to challenge healthcare professionals. We will be exploring the topic of burns, including the issues that surround the initial care of patients presenting with them. Clearly, this is not a new problem, but in spite of it being greatly reduced in frequency, cases still occur. It is the ubiquitous nature on who can experience burns that is important that all healthcare professionals have the ability to stabilize and provide initial care for burn patients. Given the infrequency of such cases, however, we thought it important that we review this topic. To help us do that, we are fortunate to have with us today Dr. Stephanie Mason. Dr. Mason is a burn and general surgeon at Sunnybrook Health Science Centre in Toronto. She is presently an assistant professor of surgery at the University of Toronto. She graduated medical school from University College in Dublin and then completed her residency at the University of Toronto. She went on to complete a fellowship in burn, trauma, and surgical critical care at the University of Washington and Harborview Medical Center. Her clinical interests include emergency surgery and the management of skin and soft tissue diseases, especially those related to thermal injury. Dr. Mason's research interests include burn health services and survivorship, with a particular emphasis on the impact of social economic marginalization on injury outcomes. Our objectives today will be to discuss the principles of initial stabilization of the burn injured patient. We will describe criteria and process for transfer to a burn center, and finally review the management of inhalation injury. Dr. Mason, Stephanie, thank you again for agreeing to present to us, and I look forward to your presentation and the discussion afterwards.
Thank you. Thank you for that introduction, and thank you for the opportunity to speak today about burns. So I have no disclosures related to this talk. My goal really for this talk is to hopefully demystify burns. I know there's something that tend to invoke a lot of fear in people. It's not something that you might encounter many times in your career, but it's absolutely something that I firmly believe every single one of you have the skills to help manage these patients. And what I'm going to focus on is how to initially stabilize and assess a burn patient, to describe the criteria and process for getting patients to a burn center and recognizing which ones might benefit from care in a burn center, and then to review the management of inhalation injury. And I chose these objectives because these are really the things that are most important to safely care for a burn injured patient in the first 24 hours, and the things that I think are reasonable to be able to accomplish at really any hospital in Ontario. So burn care in Ontario is centralized to 2 adult burn centers and 1 pediatric center. We at Sunnybrook take care of the majority of burn injured patients in the province. Hamilton currently has a burn center that takes care of patients who have a 20% or smaller burn, and anyone with a burn bigger than 20% for about the last year has been coming to Sunnybrook. And so we really see the majority of these. And then Sick Kids has a pediatric burn center to care for children who sustain burn injuries. The initial assessment of a burn injured patient is exactly the same as any other patient. So you're going to start with the ABCs. And what I want to highlight is just the aspects of the ABCs that can be a little bit different or a little bit challenging in a burn patient. So the important thing to remember is to put all of these patients on 100% FiO2. Just assume that they have an inhalation injury and put them on 100% FiO2 to start. The expected vitals for a patient with a burn injury is typically that they have a normal GCS, a normal or high blood pressure, and that they're tachycardic. If you have a patient who is unconscious or hypotensive or very tachycardic, should have a high level of suspicion for other injuries, because often what happens is that patients with burns, for example, to get themselves out of a burning house, jump out of a second floor window and sustain a broken femur and have a head injury. And we don't want to miss those things when and get distracted by what we can see on the outside. And so I would encourage you to maintain a really high level of suspicion for other injuries, especially if the patient is unconscious or hypotensive. Those are not things that we typically expect because burns hurt. So these patients usually are supporting their own blood pressure. The other thing to keep in mind in a patient who is unconscious or hypotensive is the potential for carbon monoxide or cyanide poisoning. And that would be patients who have been removed from a closed space fire. So that would be the other thing to think about if you have a low GCS or hypotensive patient. Probably one of the most common questions that we get asked when we accept consults from outside hospitals is whether or not a patient needs to be intubated. And I would say to you that during your initial assessment of a burn injured patient, the indications for intubation are exactly the same as for any other patient. So low GCS with inability to protect their own airway, respiratory distress as characterized by any combination of stridor, hoarseness, hypoxia, tachypnea, or air hunger. And sometimes a patient who has a very large burn with a facial component can be an indication for intubation as well. But if the patient doesn't have an immediate indication that you feel that they're about to lose their airway or that they can't protect their airway, then I would encourage you to stabilize the patient from an ABC perspective, and then feel free to call via critical, and I'll talk about how to do this. Call us and get our advice on whether or not we think someone needs to be intubated. Just because they have a bad burn doesn't necessarily need to be intubated, doesn't necessarily mean they need to be intubated. Oftentimes, we find that one of the main reasons patients get intubated unnecessarily is for facial burns. The presence of a facial burn itself or the presence of soot in the nose or in the mouth is not in and of itself an absolute indication for intubation. So those are ones where we're completely willing as the burn surgeons on call to have that conversation with you and make a decision about what the safe thing to do is. And of course, in making that decision, we're also going to take into account, potential transport distance, transport mechanism. And so we can, assuming that there's no emergent indication, there's really no burn specific emergent indication to intubate. So if the patient doesn't have any of those objective criteria, we're always happy to have a discussion. In terms of coming to our C of the ABCs, just some practical things that I think it's worthwhile noting. It's okay to put lines through burned skin. These patients typically need 2 large bore IVs. Just get whichever IVs you can get. And then in patients with large burns, poor peripheral access, or intubated patients, then often it's reasonable to consider central access. And generally, we only need an arterial line for intubated patients. Initial blood work is just like any blood work you would do on a newly presenting patient. And we typically add a carboxyhemoglobin to look for carbon monoxide poisoning. So once we have a sense of the ABCs and the patient's stable, we're going to start thinking about splitting patients into two bins, really. And that is whether the patient has a minor burn, which is a stable patient, not intubated, less than 20% of their body surface area is burned. And then the major burns, which are either the bigger burns, those that are intubated. And then, the things that I put in red there that can kind of go either way. Patients who have very deep burns, patients who have circumferential burns to one of their extremities, or patients with comorbidities might, even if they're not necessarily a big burn or an intubated burn, might still sort of be treated like a major burn. So how do we decide that? So burn size is something that I don't want you to worry about until after you've stabilized the patient, taken a deep breath, put warm blankets on the patient, and had a moment to gather yourself. There's lots of different ways to estimate burn size, and there's no right way to do it. And if you line up myself and all of my colleagues and ask us to estimate the burn size of a particular patient, I guarantee you that none of us would pick the same number. Okay, so this is very much an art and not a science. There's lots of different ways to do it, but what I recommend is that typically, because most people in the community don't see very many burns, they probably don't remember the rule of nines. The simplest thing to do is Google TBSA. And one of the first Google image hits that comes up is going to be this chart right here. And basically what that does is just lets you look at the patient. I typically recommend printing it off, and I still do this myself. Print it off, stand in front of the patient, and just fill it in. And it'll just ask you to estimate, okay, what % of the head or face do I think is burned? How much of this arm, how much of this leg? And this can be really rough. This doesn't need to be detailed in any way. And you might be thinking to yourself, but aren't I going to base all of my fluid decisions on what this number is? And we'll come to that, but really, no, you're not going to do that. And I think one of the important things to remember is that first-degree burns don't count. So one of the most common reasons that patients are over triaged to the burn unit is because first-degree burns have been counted in the calculation. So skin that is just red and pink and looks like a sunburn but is intact, that does not count in your TBSA. So you're only going to count the skin that has sloughed off and has that moist, pale pink or white appearance. If the skin is intact, it does not get counted in this number. So fluid resuscitation is really the cornerstone of the first 1 to 24 hours of burn injury. This is really the main thing that, and the most important thing that impacts the patient's outcome. The American Burn Life Support Guidelines, which is really ABLS is the burn equivalent of ATLS, recommends that for an adult, you just start with 500 cc's an hour. And so if you can remember one number from this talk, the number to remember is 500. And so you don't need to, print off that chart and estimate the TBSA to begin fluids. Just start with 500 cc's per hour of Ringer's lactate. It's a starting point. We can always titrate it down the road, but just pick a number and stick to it. So the ABLS guidelines are 500. For a child, it's 250, and for an infant, it's 100. But what I like to remember as a good rule of thumb is if you just ballpark an estimated burn size and add a 0, that's a great starting rate. So if you think that it looks like about 25% of the body has been burned, add a 0 to 25, you get 250 and start at 250. But you really can't go wrong here. That's what I want to emphasize. You can pick any number. The main thing that I would like you to remember is that you got to start fluid, start it with Ringer's lactate, and don't bolus these patients. So oftentimes what happens is these patients, I think there's a bit of a sense of urgency around knowing that these patients need fluid. And they very quickly, within the first hour in an emergency department, get 2 to 3 liters of fluid as a bolus. And that all that does is produce lots and lots of edema that can actually convert the depth of a burn. So this is started as a rate, and it's Ringer's, and just pick a rate. And now you're probably wondering, what about the Parkland formula? So the Parkland formula, as many of you probably know, is 4 cc's per kilogram per % body surface area burned. And what that is meant to do is predict how much fluid a patient is going to require in the first 24 hours after their injury, where half is anticipated to be needed in the first 8 hours and the next half in the following 16 hours. But what we know is that for a lot of patients, the Parkland formula overestimates how much fluid is required and leads to patients getting too much fluid. And the other thing that it does is it kind of locks patients into a fluid rate that they might not need. And so I prefer to avoid a very formulaic approach to resuscitation, and I prefer a much more dynamic approach to resuscitation. And what that means is pick a starting rate, and then every hour we just reassess the patient and see how they're doing. And this is very simple to do because most of it is driven by the urine output. So every hour, check the urine output. Let's say you remembered the number 500 from this talk. So you started at 500, and an hour later, you're going to check the urine output. If it's 60, then great, you met your goal. Turn the fluid down a bit by 10 or 20%. Next hour, you got 30, great, keep the fluid where it is. Next hour, and so on and so on. And so you can see that if that's your approach to resuscitation, it becomes much less important to get a really exact or clear body surface area up front, as you would need to apply one of these formulas. And it applies a much more patient-centered approach that means that overall the patient is much less likely to be under or over resuscitated, because one of the big challenges with resuscitation is the morbidity that's associated with either giving too little fluid, largely kidney injury. Often these patients become dialysis dependent if they get too little fluid. And with too much, they can run into a lot of problems with pulmonary edema, ARDS, and abdominal compartment syndrome, and those all carry a lot of morbidity in burn-injured patients. So I would really encourage a much more dynamic approach and just turning the fluid up and down. This is a little bit of a dance. We just turn it up and down according to the urine output. And you can use other things to inform whether or not you think you're giving enough fluid. So we want a urine output of 30 cc's per hour. We also want to aim for normal or normalizing hemodynamics, meaning the heart rate is coming down, patients are normotensive. And typically these patients will have a high lactate and base deficit to start, and you should see that improving. If you see on subsequent blood work, and I usually do blood work every 6 to 8 hours for a new burn, that the hematocrit is high or the hemoglobin's high or those numbers are trending up, usually means you're getting a little bit behind, even if the patient has a good urine output. So in summary, for the initial stabilization, ABCs, intubate if the patient seems to be in respiratory distress. Otherwise, perhaps consider a conversation with one of the burn docs. Estimate the burn size, treat the patient's pain, decide in your head whether or not we're going down a minor or major burn pathway. If it's a major burn, start fluids and keep them warm. And then you're going to think about calling for help. So these are the burn center consultation guidelines from CCSO. What I would say is that these guidelines are a great place to start, but I would encourage you, if in any way in your head you're thinking that you have a question or a concern or you're worried about the patient, even if they don't exactly meet these guidelines, we're always happy to take the call. So just call us through Critical. There's always one of us available 24/7 to take that call from you and help. But in general, the patients that should be considered for transfer are anyone who has a 20% or greater body surface area burn, or 10% burn in the extremes of age. Patients with any size burn and an inhalation injury, older patients, and then anyone with electrical and chemical burns, as well as sort of functionally significant areas, so burns to the face, feet, hands, and perineum. Patients with comorbidities we tend to have a lower threshold for transferring those patients. So these are the criteria, but like I said, any concerns or questions, if there's any sort of niggling in your mind, just give us a call. So what's going to happen when you call us is you're going to be connected to one of the burn surgeons on call. There's 5 of us that work here at Sunnybrook, or you might get connected to Hamilton. Typically, Hamilton only gets referred the patients who are in their catchment area, and we get referred everybody else. So we'll talk about the case. Oftentimes we're going to ask for photos because those help us a lot to guide things. And then what's going to happen is we're either going to accept the patient, we're going to provide advice and arrange follow-up as needed, or we're going to provide support. The reason we might provide support is because the patient doesn't necessarily meet criteria to come to the burn unit, but perhaps has an isolated inhalation injury that can be managed in a local ICU, perhaps just needs a couple of days of pain control before they can go home, or has some social issues that mean that they might be better served by a short stay in another hospital. If we do accept the patient, it's going to be either as a life or limb for the life-threatening burn injuries. Those are typically the large burns, the intubated burns, or patients who have a circumferential burn causing a compartment syndrome. And then the others where, you know what, they meet the criteria to come. It's not a life-threatening emergency. We need a little bit of time to adjust resources on our end to be able to safely accept that patient while also caring for the patients we have here. And if that's the case, you know, it's possible that the patient, we might ask for you to keep them for the first 8 to 12 hours while we make arrangements. And that's why I think it was important for me to really emphasize what needs to happen for a burn patient in the first 24 hours and help everyone feel comfortable that it's definitely something that's really practical to do. So I mentioned already that fluid resuscitation is really the cornerstone of the first 24 hours of burn care. So fluid resuscitation is the main thing that's going to be going on, and then pain and sedation management. Otherwise, patients just need a dressing change once a day. We will advise and give you all the information you need to know how to do that first dressing if you're going to keep them there. Oftentimes what we'll say is to just keep them covered with clean green towels, and we'll take care of the dressing when they get here because we're going to take it all down anyway. So really the most important things are to keep the patient comfortable, keep them warm, and manage their fluids. Everyone can do that. We typically start enteral feeding right away. These patients do not require antibiotics, and they also don't require any activity restrictions or bed rest, though most of these patients will not be getting out of bed, the big ones anyway, in the first 24 hours. Fluid resuscitation typically continues for 24 to 48 hours, sometimes a little bit less, sometimes a little bit longer. And I typically consider a fluid resuscitation to be complete when the patient has reached an hourly rate that is around their maintenance rate. So that just requires titrating the fluid rate to the urine output every hour. Usually after 8 to 12 hours, you can start really making some improvements and coming down on the fluid. But some patients are going to need you to go up on the fluid. And they might tell you that because their urine output's falling off, or they're looking hemoconcentrated on their most recent blood work. And so I talked about this a little bit, but the fluid resuscitation approach can really be quite simple. Choose a starting rate based on whichever method you like. The rule of tens, where you just add a 0 to the estimated TBSA, or you just start at 500 cc's. Every hour, assess the urine output, assess hemodynamics. So consider and integrate any new information that's come up. And then just titrate the fluid up or down by 10 to 20%, depending on how close to your goal you are. So typically, I find that if the urine output is within 10 of my goal, I only adjust up or down by 10%. And if it's within 20 of my goal, I adjust up or down by 20% to keep it nice and simple. And then for patients who still have a high fluid rate around 8 to 12 hours, or who you're still having to go up every hour, where every hour you just find you have to keep giving more and more and more, you're going to start thinking about a patient perhaps is failing the resuscitation. And that's a sign that if the patient, for whatever reason, if you haven't talked to us yet, or the patient's still there, reach out again, and we can review what's going on and give some help. But basically, any patient in whom the labs are worsening, can't get the urine output up, or they're hypertensive, or you're starting to get into issues with multi-organ failure, pressor-resistant shock, or difficulties with ventilation, you should think to yourself, this isn't as easy as she said it was going to be. Okay. It's a good point to stop and just think, you know, have I missed another injury? Is this patient bleeding from a broken femur that I missed? So stop, you know, go back to, just like they teach in ATLS, you go back to the beginning, start at the ABCs again. But if you've checked all that and you're pretty sure that the Foley's working, and this is really truly just that the patient is not responding to your resuscitation, then the most likely thing you're going to do is add albumin. So we typically avoid albumin in the first 8 to 12 hours after a burn. And the reason for that is that the pathophysiological response to a burn injury causes increased vascular permeability. And so even if you put albumin in, you just create very expensive edema. But at about 8 to 12 hours, that response starts to cease, and the vessels can hold on to oncotic proteins again. So albumin helps to minimize how much fluid we're given. It hasn't really directly been linked to improve patient outcomes yet. So it clearly reduces how much fluid you give. Whether or not that improves outcomes remains to be seen. We typically use 5% albumin at about a third of whatever your fluid rate is. So if you're running, you know, your fluid at 900, then you're going to start your albumin at 300 and turn your, usually do 2/3 crystalloid and 1/3 colloid. Finally, I want to talk about inhalation injury because I think there tends to be a little bit of confusion around this. So when we talk about inhalation injury, we really refer to three different potential disease processes. One is a burn to the upper airways, and a burn to the upper airways manifests as swelling of the upper airway mucosa and airway obstruction. So these are the patients who are going to have stridor and dyspnea and respiratory distress. These are the patients who are typically going to need to be intubated right away. Fortunately, we have a very smart body, and we have a reflex that when fire is coming at our face, we hold our breath. And so this actually doesn't happen that often. Most of the inhalation injury that we see is actually the impact. So the upper airway absorbs the heat, but then the toxins and smoke get inhaled into the lower airways, and they cause direct damage on those airways. And what that leads to is sloughing, collapse, ciliary injury, so you can't mobilize the secretions and the rest of the crap up, DQ mismatch, and ultimately hypoxemia, pneumonia, and ARDS on a little bit of a spectrum. And then there's the systemic poisonings, which I'm not going to talk about, but that are really also effects of an inhalation injury. We diagnose inhalation injury with bronchoscopy. So this is typically not necessary if the patient isn't intubated, but if the patient is intubated, we typically go ahead and do a bronchoscopy and sometimes a bronchoalveolar lavage. The chest x-ray is usually normal initially, so the bronch is really the best way to pick up on this. And what you'll see when you do the bronch, you can see the different gradings here, is typically some soot in the lower airways, erythema, bronchuria, lots of fluid, and sometimes you just see frank obstruction. And there's a whole spectrum. The spectrum doesn't really matter. What you really want to know is just qualitatively whether it's there or not, because the treatment is going to be the same. The treatment of inhalation injury is supportive. Know that most sequelae of this don't manifest till 12 hours after the injury, so the patients typically don't have any abnormalities up front, other than the visual abnormalities on bronchoscopy. And the goals of the supportive treatment are to reduce shunt, to break down the mucus, to break down the clot, and bronchodilation. And so the regimen that we employ for our ventilated patients who have an inhalation injury is inhaled bronchodilators, inhaled heparin nebulizers, and inhaled acetylcysteine nebulizers, and we continue those until the patient's extubated. If you do find yourself in a case where the patient is going to stay locally for the treatment of their inhalation injury, we're very happy to share our protocols for inhalation injury. We do that all the time to help guide you in taking care of these patients. I'm going to leave it at that. I hope that I really convinced you that you can do this and that it's actually pretty simple and straightforward to take care of a burn patient in the 24 hours. Burn patients are complex. They do need specialized care, but I firmly believe that everyone can help these patients in the first 24 hours before they get to the burn center. Thank you.
That's great. Thanks, Stephanie. And I'll be going to Neill and Bernard in a sec for some questions. In terms of people managing them, that, you know, your comments that they can do it and things as such. I know you guys are a phone call away. Is there any aspect of virtual care? I'm just thinking as transport, particularly with some of the burden that's going on right now, may be a bit delayed. Has that been built in? Is that a possibility? And is there a role of other centers maybe holding some of the borderline ones in case one of the two adult burn centers are overwhelmed? Like, what are your thoughts on that?
Yeah, lots of good questions there and lots of things that we've been talking about, particularly since Hamilton stopped being able to accommodate larger burns. We're just, you know, it's more and more likely that when you call us, we might need a little bit of time. We'll be able to accommodate the patient, but we just might need a little bit of time. There's no formal virtual infrastructure as of yet, but I very often find myself on FaceTime with the referring doc to help. We almost always ask for photos, but sometimes, you know, I'll be put on FaceTime and brought into the room, take a look, help with things, and support in whatever ways that we can. And often what I say is, you know what, call me back in an hour with the urine output and I'll help you decide what to do with the fluid, or call me we're very aware of which patients are sort of out there waiting. Fortunately, it's rarely too many at one time. And we remain very engaged, often just by text and sometimes through Critical as well. There's also a lot more use of virtual visits for us, which is obviating the need for some patients to come just to see us. We're able to see, especially patients who live far away. Often the next day we can see them via OTN. And so that's helping a lot with reducing big distances that patients have to travel to access specialized care. There's a lot that we can do virtually.
Excellent. And my last question is, it used to be always the question about fasciotomies. And certainly virtual may be a way to help out with that aspect of it. But what are your thoughts on it? And my suspicion is it's been overdone in the past. But what would your comments, suggestions, recommendations for that be?
Yeah, so fasciotomies are really required. Escarotomies are sometimes required. And so the difference is just whether or not it's the burn itself causing the constriction sort of from the outside in, similar to if you leave an elastic band around your wrist for too long, or whether the level's at the fascia. It's rare that it's at the fascia, so that's very rare. Patients who have a circumferential full thickness burn often do need an escarotomy, but it's usually not an emergency, number one. And it can often wait until the patient comes to us to be done. And the reason for that is that the full thickness burns don't swell a lot, which actually becomes advantageous, because what happens is the reason that patients need escarotomies is because you have this constricting full thickness burn that doesn't expand as it becomes edematous. And so everything else expands and that becomes a constricting part. And so typically what we'll advise is just to keep that extremity elevated, minimize how much fluid's going in. That's not always possible. If it's a small burn, it's easier than if it's a big burn. And when, if it's really needed, I've guided an emerge doc through an escarotomy in the community over FaceTime. But I've only had to do that once. It's pretty rare. And elevation and fluid minimization goes a long way.
Excellent. Thanks. Neil?
Thanks very much. That was a great talk. I have a few questions, and if people have any questions, please direct them to either Q&A or Q&A 2 using the chat. I was wondering if you could comment on for major burns, particularly where there may be a bit of a delay in transfer for the reasons you've outlined, on sort of tips on temperature management. With often that seems to be a challenge on how to keep patients from getting too cold.
Yeah, it can be a challenge. There's a few different things you can do. So the first thing that I recommend is that you heat any fluids going in as much as you can. So the resuscitation fluid going through a fluid warmer. If there's any radiant heat available, that's helpful. Or if the patient can be in an actual room with a closed door to minimize drafts, that can be helpful. A bear hugger is fine to put on a burn. I don't know if they're called bear huggers everywhere, but I assume you all know what I mean. That's totally fine to put on a burn as long as there's a layer in between. So the burn is covered with a sheet, with towels, and then a bear hugger can be really great to keep these patients warm. The other thing that often we see is that I'll recommend just don't worry about putting a dressing on, just put clean towels. Well, burns produce a lot of exudate, and then those towels get wet, and then the patient actually is now covered in cold, wet towels. And so those often need to be changed often. And even the blankets and sheets need to be changed often because they'll get cold and wet. And so it's just frequently changing the bedding, warming whatever fluids you can put in, turn up the temperature of the room if you can, and a bear hugger.
Great. Probably most of the patients that come to the Sunnybrook Burn Center are referred in, and so you've got a lot of experience, or the center does. There's a lot of experience in talking to referring clinicians. Aside from sort of the issue of airway management, which you've touched on, can you talk about sort of what you see as the most common sort of challenging areas for management? Is it fluids? Is it like what aspects do you find that when you get the patient, you say, oh, I kind of wish something else had been done or something else had been tweaked?
Yeah, I think the two most common things that, maybe three most common things that we see are that the burn size has been overestimated. And we largely get around that now by asking for photos. What happens sometimes is if the burn size gets overestimated and we haven't seen photos, that the fluid gets started often at a rate based on that burn size. And that's one of the reasons why I kind of advocate not to base your fluids on the burn size. Because sometimes what happens is a patient with a relatively small burn comes to us intubated, and they've gotten like 10 liters of fluid. And so we actually end up, the patient's outcome is affected by how much fluid they got rather than necessarily their burn. You know, a little bit of pulmonary edema becomes a VAP and longer time on the ventilator and so on. And for patients with comorbidities in particular, that can create some challenges. The other thing that we find is that there tends to be a tendency, I think I mentioned this during the talk, to bolus these patients. And typically my recommendation is to only bolus a burn patient if they're hypotensive, otherwise just to titrate up and down the maintenance fluid. Because what happens is when you give a bolus, the majority of that bolus ends up in the burn tissue, creates swelling, and you might think that's not that big of a deal. And in a lot of patients it isn't. But in some patients, it's the difference between a burn that needs grafted and a burn that doesn't need grafted, because that extra fluid can just contribute to some local ischemia that makes the burn deeper than it was and suddenly becomes a burn that needs an operation. I think that a lot of the fluid challenges stem from sort of a desire to stick to a very formulaic approach to burn resuscitation, which, don't get me wrong, I think totally comes from a place of wanting to do the right thing for these patients. And everyone remembers the Parkland formula. And so people are often very caught off guard when I tell them not to use the Parkland formula. But oftentimes we don't get involved until they've already started and are a few hours down the road. But it's never too late to turn the fluid down.
Great, thank you. A couple of other, I guess, maybe sort of specific clinical questions. You mentioned for peripheral IVs that it's no problem to put them through burn tissue. What would you say for that also hold if the patient needs a central venous access? Or
it does. So sometimes we don't have a choice sometimes. So sometimes the neck's burned, sometimes the groin's burned, sometimes they're both burned, or the chest. And so I would say get the access that the patient needs. And, you know, if we can change it for an area through unburned skin later, we will. You know, not unsimilar to when we put in dirty lines in a sudden resuscitation, where the goal is just to get the access and, you know, we can change them out for clean ones later. If we have the luxury, great, but sometimes we just don't have the luxury of intact skin over the places that we want to put a line. And so we manage that. One of the, practically speaking, challenges of putting a line through burned skin is just keeping it secure, because the dressings don't want to stick to the burned skin because it's very moist and wet. And so I'd recommend, if you are putting a line through burned skin and you want it to stay in, sew it, and sew it well.
great. Maybe just one more specific question. Going back to escarotomy, is it it's probably a very uncommon scenario where, you know, a referring center would have to consider doing a chest escarotomy for inability to ventilate, but especially early in resuscitation. But I'm just wondering if you can comment on that.
Sure. So sometimes patients who have full thickness burns to their chest, often when they're on the chest and going around the flank, can develop some challenges with ventilation because it becomes like a constricting force around the chest wall. And so those patients sometimes require chest escarotomy. I'd say it's rare even for us to have to do it. And the other thing that I hope is reassuring is that it typically doesn't become a problem until well into the fluid resuscitation phase, because the patients started to get a lot of fluid. need a little bit higher airway pressures to keep them ventilated. And that's when it starts to become a problem, especially as the unburned skin starts to swell on either side. If it does need to be done on an emergent basis, crazier things have happened. We would talk you through it, but it really requires either a blade or cautery. These tend to not bleed very much because it's dead skin. And it's pretty easy to do. I do this with medical students all the time. And usually, the one time that I've had to do it, it was because a patient was stuck 18 hours away in Alaska by air. And we did it over FaceTime, and it was like I was right beside them, because someone held the phone while the person did it. And I talked to them the exact same way I would as I talk to a resident when I'm trying to teach them the procedure in the OR. Somebody's like, oh, a little bit too deep, a little bit less. I think video technologies like that have really expanded what we're able to do. And I think sometimes in tertiary care centers, we're a little bit guilty of underestimating how much skill actually exists at these small hospitals sometimes.
Great, thank you.
Excellent. Thanks, Neil. I'll go to Bernard in just a sec. My last question is just going to be on the role of hyperbaric. Whether or not, let's say you have a carbon monoxide with a significant burn, is it preferable to do a dive before sending, recognizing that perhaps the burn management may be less than ideal, or which takes precedence, I guess, is where I'm trying to go.
Yeah. So what I would say, this comes up from time to time. There is some data to suggest an improved outcome in terms of delayed neurological sequelae for carbon monoxide poisoning with hyperbaric therapy, but there's also a lot of data that suggests that there's no difference. And so if it is logistically reasonable for the patient to go for a dive, we'll often recommend it, but that typically is a patient with an isolated inhalation injury, meaning that they don't actually have a burn on their skin. If they do have a burn, it just becomes a logistical nightmare, because it's very hard to do the wound care that's necessary, to do the nursing bedside care that's necessary, to run the resuscitation with a patient in a tank. It's just impossible. And the other thing is that we don't have a tank at Sunnybrook. So it becomes, there's another center that needs to get involved. And so most of the time I would say the answer is going to be no. If it's a patient that doesn't have a burn and does seem to have carbon monoxide poisoning with some early neurological symptoms, it can be beneficial. The data isn't strong enough that I would really push hard for it to be done. Okay. And it's certainly not worth the downsides of affecting all the other aspects of burn care that we know to be much more important to outcome if the patient has a burn on their skin.
Excellent. So I'm going to go to Bernard, and then we'll get some final comments, and then we'll get Bernard to close.
Great. Thanks, Dave. And thanks, Dr. Mason. That was an excellent presentation. I think it was a very good overview of, sort of refamiliarizing people with that initial phases of resuscitation in those first 24 hours, so that it hopefully doesn't seem as daunting as has been noted. Sometimes when those things that come in that you don't see very often, it's easy to feel like that sense of like, oh my gosh. And it's a good reminder for people that it's resuscitation, it's ABCs, and there's a few specifics to it for the burns as you've outlined. But most people in the first 24 hours should be able to effectively manage these and manage it appropriately and feel like they're doing it appropriately. So that's a great overview. Thank you very much. I'll make one clarification, is that it's not a permanent thing that all of the patients with greater than 20% body surface area are being transferred to Sunnybrook. Hamilton will still take them, but they're just in a bit of a MD staffing issue right now. And so while they're sorting that out, Sunnybrook is taking some of the larger burns, and it was quite a crunch this summer. So it was a lot of work that Sunnybrook did to accommodate that. But that's the value, I think, of having two burn centers in the province. People sometimes will ask, like, do we need two adult burn centers? And it has been very effective, because sometimes even there's times when, Sunnybrook has gone down on their MD complement, Hamilton's taken the bulk of patients in the province. And so there's it's good to have a backup. And but the other piece about that is the increased collaboration that's happened over probably the last 8 to 10 years between the two sites. And so that's very handy and useful. And Hamilton does actually have a hyperbaric chamber. And like, as you mentioned, Stephanie, I don't know if it's actually used frequently for burns. It may be used more for other like skin conditions or anaerobic infections, things like that. But that was a great question, Dave. I have a question, and it's because one of the things that we talk about around the burn committee is, you know, some of the burns and burn care that will happen locally, and some of it very good, but there's always that sense of, are there some burns that are getting sent that don't need to come to a burn center, and some burns that are being kept and managed at some of the smaller hospitals where they actually should recognize perhaps that it should be sent sooner. Do you want to, I know you're familiar with some of the data on that. Any comments or questions? Because I think that's good for some of our participants today from local hospitals, just to have a little reminder of that as well. Yeah,
so we looked at the data around this, around where patients in the province are receiving their burn care. That was a few years ago now, but at the time, I think our data went through 2014. We knew that about 30% of patients with a 20% or greater burn were actually being cared for outside of burn centers and outside of trauma centers even. And so we know that there's some community hospitals that are taking care of these patients locally, sometimes probably appropriately and sometimes probably inappropriately. And so one of the things that we're working on is trying to increase our outreach to the hospitals that refer patients to us and make sure that they realize what resources we have available, even for patients that don't come. I think what tends to happen is that, you know, there's a patient with maybe a minor burn, but a small burn can still be very life altering, especially if it's on a functional area. And so they might think, oh, I don't want to call critical for this hand burn. We'll refer it to my local plastic surgeon. And I think sometimes people, there might be a little bit of gap in realizing that the resources available, that, you know, absolutely call me through critical for a small burn and we'll arrange follow-up. And I think also sometimes it's important to remember that patients have a say in this too. And some patients might just prefer to be cared for closer to home and accept that they might not get the same level of care. But I think we have a bigger role than sometimes smaller hospitals might think in what we can offer virtually and you know, within the patient's wishes. So I think there's a lot of room through things like this to expand everybody's knowledge about what resources are available, but also to recognize that we're happy to help even with the patient. Just because we don't accept the patient and transfer doesn't necessarily mean we're not going to take care of the patient on an outpatient basis.
No, and that's true. And I think it highlights, I think, the value of that phone call, even if they're not sure, or even if they feel like they're sure, if they should just check. It's always, I think, a good value place to call to critical. Critical will then, you know, triage it, or not triage it, but filter to either Hamilton or to Sunnybrook, or in the case of children, to sick kids. And then at least you get to talk to somebody who's really going to be able to give you some good advice. And maybe the decision would be to stay at their local hospital. But I know there's lots of times in burns and some of the other programs too, where there'll be that extra contact later, so that you can still keep tabs on how they're doing and making decisions around, as you said, some of the initial management, or, you know, does it turn out that the patient actually might need to be transferred after all? So those are things I think for some of the peripheral sites to keep in mind. I know there was a lot of education a number of years ago, and things for, you know, as reminders of people to try to decrease incidence of burns. And we probably haven't seen a huge change in it recently. What are your thoughts around, you know, the incidence of burns in general, and where there would be, if there are, areas for injury prevention or burn prevention that we could do?
Yeah, it's a good question. So the incidence of burn has actually remained relatively stable. There were huge improvements in the 80s and early 90s as lots of things started becoming regulated in terms of fire exits and smoke alarms in apartment buildings and things like that.
No candles on Christmas trees.
And so unfortunately, I think the low-hanging fruit has been plucked. And it's taken a while to identify what the next step is. And I think that's why the rate has remained relatively stable over the last 10 years. The group that we are seeing burns increase in is the elderly. And you know, a lot of those are things that aren't necessarily easy to prevent. Even in younger people, a lot of burns are caused by inattention. and it's hard to have a public health intervention for that. Inattention and intoxication lead to many of the injuries that we see. There's a lot of successful work that's been done around children, staying away from pots on the stove and things like that. But I think for the elderly, there's an opportunity to sort of talk about safety around the stove, around boiling water, around hot water bottles. We see a lot of little old ladies with a ruptured hot water bottle, or even not even that the hot water bottle is intact, but their sensation is just lower and it's just too hot, and they fall asleep with it and it causes a contact burn. And similarly, I think there's a lot of room for counseling of patients with peripheral neuropathy around the temperatures of things. We often see in old buildings that there are regulations around how hot water should be, but it's often not checked. And so that often leads to a lot of the injuries that we see. So it's pretty heterogeneous. And so it's hard to say exactly what the next best public health intervention is. But as we start to see trends, we usually try and get information about them out. So a few years ago, the backyard gas, not barbecues, but yeah, they started to become popular, and all of a sudden we saw a bunch of burns related to them. And so we usually make an effort to talk to the media and get some sort of messaging out around those. And the regulations around them actually changed in terms of their safety. So we try and react to trends as we see them. But probably the most common trend in burns for the last 50 years is inattention. It's hard to know what to do with that.
I'm smiling a little bit because we did just put one of those fire pits in our backyard. And I would say, not for me, but for commonly, there's probably a lot of drinking around those fire pits, and it's not probably untoward that there'd be some injuries.
Yes.
It's interesting. You raised some good points, I think, of where we may be able to do injury prevention, but thankfully it's there was a significant effort. And I know that some of the fire associations and the firefighters associations have been significantly involved in some of that as well. So good partnerships from the burn centers. I don't have any other questions. I would check and see if anything else has come in. I don't see it.
I think Neil has one final question.
Go ahead, Neil.
And I'll just remind everyone to do their best to do the survey that will get posted and sent to you. It'd be appreciated, and feedback and comments and suggestions going forward on that. So I'll go to Neil and then go back to you, Bernard, and I'll reconsider building my fire table that I had planned.
You have to put it outside, Dave. You can't keep it inside.
So, Neil?
One final question is around, excuse me, around when to suspect cyanide toxicity, and do you think that we sometimes think about that too frequently if the patient's not responding to resuscitation, and how you approach that problem?
Yeah, cyanide toxicity is a tricky problem. We don't really know the true incidence of it. All of the data we have is from coroner and autopsy studies. Most of the patients, so you should really only suspect it if the patient was in a closed space fire. And most commonly, these patients are unconscious and hemodynamically unstable, with a lactate usually greater than 20. So those are sort of the harbingers of badness. And the treatment, I'll just quickly mention. So number one, most hospitals can't test for cyanide poisoning. And the test takes about 2 hours to come back, even if your hospital offers it. So you need to just have a high index of suspicion and treat on spec. The treatment is cyanokit or hydroxycobalamin, which actually binds or chelates cyanide in the blood and converts it into vitamin B12, which gets peed out. So if there's my advice is that if your patient is unconscious or hemodynamically unstable, to just give it. Most emerge departments have it readily available. The paramedics also carry it, at least in Toronto. And there are some downsides to giving it. There's some probably risk of renal injury that's coming out. But if it means the difference between a very poor neurological outcome or some kidney injury, I think on balance, most of us would give it. If the patient is awake and talking to you, they don't have cyanide poisoning.
Great. Very
Excellent.
useful clinical pearls there. Thank you.
Nice quick summary. That was very excellent. So Stephanie, thank you again for taking the time to join us. We certainly encourage people to join us for the next talk, which we're still finalizing and will likely be related to the ongoing COVID crisis. And for the final words, we're going to go to our CCSO leader, Dr. Bernard Lawless, for closing comments. Thank you again.
Thank you, Dr. Neilipovitz, for your excellent job at moderating today's session. And Dr. Mason, just want to thank you very much for being able to give this great presentation today. I think a lot of valuable learning in there, and just I think the reminder that these are things that we can manage in the first 24 hours, especially in some of the peripheral hospitals. And so it shouldn't be as daunting, but the burn centers are also just a phone call away if they need to reach out to speak to anybody. So I think those are very key reminders for folks and takeaways for the session today. So thank you. Your time is valuable, and we appreciate that you'd spent some of it with us today. Thank you to all the participants who were able to join us today, and thank you to our committee, Dr. Josée Thériault, Dr. Mike Sullivan, Dr. Neill Adhikari, and Dr. David Neilipovitz, Crystal Pitfield, and the CCSO gang. A lot of work was into keeping this going and to organizing it and to having it go fairly relatively smoothly on air. So thank you to everybody. And as Dr. Neilipovitz has mentioned, we will be finalizing the details, hopefully, of our next one very soon and getting information out about that for another OC3PR in February. And so I think that's it. Thank you, everybody.
Thank you.